Hi, my name is Dr. Jim Del Rosso from Las Vegas, Nevada, and it's a pleasure to this evening introduce Dr. Julie Harper, who is in private practice of dermatology in Birmingham, Alabama, and also clinical associate professor in the Department of Dermatology at the University of Alabama in Birmingham. And Julie has had a long-standing interest in acne. She's done a lot of publishing, has a lot of clinical experience and a lot of clinical research in acne, and has a special interest in the use of oral contraceptives and hormonal therapies in the treatment of females with acne. So welcome, Julie.
Thank you, Jim.
Now, Julie, let me ask you, when do you consider using oral contraceptives in the management of acne vulgaris? When do you consider oral contraceptives to be an option?
Well, they're frequently an option in our female patients with acne. I do think that some people, when they start thinking about using oral contraceptives to treat acne, they really try to hone in on that person who has obvious signs of hyperandrogenism. So maybe they're just putting these birth control pills to use in women who also have obvious hirsutism or have irregular menstrual periods. And I'll tell you that these can benefit women who don't have signs of those problems as well.
Do you consider them in teenage patients as well as patients that have acne after the teenage years? Because a lot of times when we're discussing hormonal therapies like oral contraceptives and spironolactone, they seem to be pigeonholed for the women that are past the teenage years. Do you consider oral contraceptives an option in teenage patients?
Absolutely. I do that frequently. I will say these oral contraceptive pills, both the ones that are FDA approved to treat acne and those that aren't, most of them are FDA approved down to the age of 14 or 15, and I certainly feel comfortable using them even at those early ages. I do think it's important that a young woman has established a pretty regular cycle before we start these. If she hasn't, she still may benefit from the pill, but I'm going to get her pediatrician or a pediatric gynecologist involved to help us with that. But I feel very comfortable using them at a young age. In fact, that's probably where I use them the most, would be teenage years up through the 20s.
Are they one of your starting options, or are patients typically treated first with the standard topical therapies, oral antibiotics, et cetera?
That probably does differ with age. So in that younger person who comes in, I always start with more traditional therapies. So I'm going to be using topical retinoids and topical benzoyl peroxides and maybe antibiotics. But if we really notice a cyclical wave of the acne, or if the woman just doesn't respond as well as I would like them to, then I certainly will add that on. In a person who comes in their early 20s, for example, they may have already been on some of those traditional therapies. They also may already easily put together that their acne is worse at certain times of the month and at certain times during the cycle. And in that case, I'm very likely to go ahead and start that treatment on the very first visit, as long as they don't have any reasons not to take it. But even then, I'm going to be using that hormonal treatment in combination with traditional therapies.
Do you find that oral contraceptives help more in patients that have perimenstrual flares?
That's a difficult question to answer. I certainly think they have a role there, but I have had such success with oral contraceptive pills, even in somebody who has a full face of comedonal acne. So it's not always that lower face hormonal acne that seems to flare premenstrually. Really, any female acne that's not responding to traditional therapy, I think, can benefit from hormonal therapy.
How long does it take before you notice the benefit of oral contraceptives in acne? Is it something that you'll see when you see them back in a month or two, you'll notice a difference? Because I've often heard that it may take 3, 4, 5, 6 cycles before you actually see benefit.
That's exactly right, and it's absolutely crucial that you tell your patients this up front. And that's not based on just hearsay. If you look at many of the clinical trials that are performed with these drugs, the effect and the result really doesn't separate from the placebo until you hit about the end of the third cycle. And that's when I tell people to expect to see some improvement around the end of the third cycle, but they should continue to see improvement up at 6 and 9 months of treatment.
Now, when do you feel that oral contraceptives should not be used in the management of acne?
There are certainly times you should not prescribe a birth control pill or an oral contraceptive to treat acne. There are definite contraindications, and you want to take a great history before you prescribe these. The biggest contraindication, I think, is cigarette smoking. So if you have a patient who smokes cigarettes, I would not prescribe an oral contraceptive. But also things, obviously, like pregnancy, history of breast cancer. Anyone over the age of 35 who is a heavy cigarette smoker is certainly a contraindication. But again, I've got to tell you, in my practice, anybody who smokes any is not going to get the birth control pill from me. Hypertension, having a history of diabetes or a history of a blood clot, all of those things are contraindications, and birth control pills should not be prescribed to that individual.
What about history of migraines? I've heard that may influence prescribing oral contraceptives.
That is certainly true, and that is one that will come up. Our patients frequently do report having migraines. The actual contraindication is that a person with migraine headaches who has focal neurologic symptoms or who has that aura associated with it should not take a birth control pill. Now, again, in my practice as a dermatologist, if you have a history of migraines, you may do great on a birth control pill, but you're not going to get it from me. I don't really go down that road and ask, do you have aura? Do you have other neurologic symptoms? If you have a history of migraine headache, we're going to get someone else involved if we need to use a hormonal therapy.
Now, what about some of the individual adverse events that can occur, like cardiovascular events or breast cancer, etc.? I've seen you present on this topic, and one of the things that I really like that you do is you go over the relative risks if women are using oral contraceptives or if they're not, with some of these individual adverse events, and that allows us to discuss with patients very directly what the relative risks may be and put it into a language that they might understand. So can you discuss the concept of woman years and go through some of those individual adverse events and make the comparisons for our listeners?
Certainly. So we're going to first talk about venous thromboembolism. Keep in mind that a woman who is not on any hormonal therapy at all has a risk of about 3 per 10,000 woman years of having a venous thromboembolic event. A woman year, 10,000 woman years would be if 10,000 women took a birth control pill for 1 year, that adds up then to 10,000 woman years. So 3 per 10,000 if you're not on a birth control pill. We do know the risk with oral contraceptive combination pills is tripled. So that number goes up to about 8 or 9 per 10,000 woman years when a birth control pill is taken. And that seems to be pretty consistent across the board. There has been some special attention given recently to third-generation progestins, androspironone, and I have reviewed the literature on this, and there does not seem to be a significant difference between any of those progestin agents and the risk of venous thromboembolism.
What about other cardiovascular events?
Yes, there are other cardiovascular risks associated with oral contraceptive use aside from venous. So stroke risk, for example, we know there is a 2.5 time increase in ischemic stroke in women ages 20 to 24 who use birth control pills, and that risk is directly proportional with estrogen dose. And that's something on the arterial side and the venous side that you will hear over and over again, and that is risk goes up as estrogen dose goes up. So it's important when you're getting comfortable prescribing these birth control pills that you really pay attention and find products that have low estrogen that work well for you in your practice. But also, back to stroke risk, hypertension, cigarette smoking, migraine headaches substantially increase that risk. As far as heart attack is concerned, we know that 80% of heart attacks among OC users are attributable to cigarette smoking, and the rest occur in people who have other risk factors like hypertension or diabetes.
Is there any specific relative risk information in relationship to any of the specific cardiovascular events?
Well, we've already talked about the venous side. Again, when you're back on the arterial side, and in the study that I will quote, which was by Dinger in Contraception in 2007, they lumped all the arterial thromboembolic events together, and I'll tell you the numbers are lower than they are for venous. So numbers like 3 arterial thromboembolic events per 10,000 woman years in women who were on birth controls that contained levonorgestrel. And if they looked at those that contained drospirenone, which is in products like Yaz and Yasmin, the number was 0.7 arterial thromboembolic events per 10,000. And that's not to say that there's a big difference between those. That's to say that these numbers are really incredibly low. When you're talking about 10,000 woman years, we're looking at numbers around 1 to 3 events per 10,000 woman years.
And that's not much different than what might happen in the general population, I would think.
that's not much different than in the general population.
Now, what about breast cancer risk?
Breast cancer risk is a trickier one. I think the jury is still out on that. There is some evidence that shows that taking a birth control pill does increase your risk while you're on it, but that number comes back down to the normal rate in the population quickly after stopping the birth control pill. And the thought is that the birth control pill likely acts as a promoter to a lesion or a precancerous lesion that's already present in those women, because we see the effect while the birth control pill is on board, but the risk goes away once it's withdrawn.
What about if there's a family history of breast cancer? Will you still give, like in the mother or sister or, of a patient, will you still prescribe an oral contraceptive to that patient even though they don't personally have a history of breast cancer?
The answer is sometimes. Now, the contraindication is a person who has had a breast cancer themselves. And to my recollection, there's no evidence to support that having a family history actually increases a person's risk. Now, I will say, just from a practicing clinician standpoint, when a patient tells me that they have a strong family history and they're already nervous about that, frequently it does change my attitude and I don't prescribe a birth control pill. But that's more based on just being a clinician and less about really knowing the data.
You base it based on the individual interaction with that patient and
yes.
and their
comfort level. Yes,
and your feeling about that patient in terms of their follow-up, et cetera.
That's correct. That's
now,
correct.
what about the whole idea of if you're the dermatologist prescribing an oral contraceptive, you're not necessarily going to be the one doing periodic pelvic exams and pap tests and that sort of thing. What's your feeling on that?
Well, I'm so glad you asked that question because I think this is a sticking point for a lot of people. And I think dermatologists who are not actively prescribing birth control pills for women with acne are really missing out on a great opportunity to help those patients get better. And the most common reason they don't is I think they are concerned that they're not doing this pelvic exam, they're not doing the pap smear. So maybe they're not prescribing these as safely as they should. But the American College of Obstetrics and Gynecology has said a pelvic exam is not necessary prior to starting a contraception in a teenager. The World Health Organization has said a pelvic exam is not necessary for safe use of combined oral contraception, even as a contraceptive method. And here, many of our patients are going to be using this strictly for acne. I know some are going to also be using it for contraception, but starting that therapy does not in any way mandate that the woman go through a well-woman exam, a pelvic exam, or a pap smear.
One of the concerns that I've heard some of our colleagues mention is if you're prescribing an oral contraceptive to a teenager, they may now think, well, gee, I don't have to worry about a condom because I'm on an oral contraceptive, and then you have the whole issue of a lack of protection against sexually transmitted diseases. Do you work in some form of discussion about sexually transmitted disease prevention, depending on the patient?
I certainly do. I would have to say I probably don't do that 100% of the time, but I make a great effort as I'm giving my whole counseling effort about this, and I'm telling patients, I don't want you to smoke while you're on this. And I teach them how to take the pill. If you miss a pill, even if you're not using this to prevent pregnancy, you don't want to miss these pills. It's going to make your periods irregular. You're going to experience more side effect from the product. And then I also say this product, if you do choose to have sex, is not in any way going to protect you from sexually transmitted diseases. You will also need to use a condom or a barrier method that would have some ability to protect you. So I think it's really important if we're going to prescribe these and we know they may be used for reasons other than what we're prescribing them for, that we appropriately counsel our patients and be responsible prescribers.
Do you have any final comments on the use of oral contraceptives in the management of acne before we close?
Yes, one would be I am receiving questions. I got an email just this week about there have been advertisements saying that a certain group of oral contraceptive pills may have a higher risk than others. And what their question is should I stop and move that patient to a different pill? Well, first of all, I think we've already covered the fact that there does not seem to be one progestin-containing oral contraceptive that's higher risk than the others. They seem to be the same. The risk is still most highly associated with the estrogen component. As far as changing someone, I would remind everyone that the highest risk period of something like a venous thromboembolic event is the first 12 weeks of treatment. It doesn't mean they can't happen after then, but you are most likely to have a clotting problem early on in treatment, and that's probably because we're finding people who have an inherited thrombophilic tendency that we're uncovering or unmasking early in therapy. So when that patient calls in at 5 or 6 months and they say, hey, I've seen an ad or my mom has seen a commercial, we're worried, we wonder if we should change to another pill, you can reassure that patient, we're already past the high-risk period anyway, and I don't think changing to a different product is necessary.
Well, Julie, I think this has been very, very helpful, and I know our listeners will benefit from all the work you've done in going through the literature and digging out a lot of very valuable information. I want to thank you for your time. I really appreciate it.
Thank you. I appreciate you and the opportunity to share this information.
Okay. Have a good night.
Thank you.